morning, everybody. We will get started here in just a minute. Everybody is coming in right now from the waiting room. So thank you for joining us. We're going to go ahead and get everybody admitted to the Zoom meeting today and give all of those of you who need recording privileges, so you can go ahead and have your own recording. We will also be recording today's conversation. So if you do need a copy, you can reach out to myself or Taylor Wilson, and we'll make that available to you later. Just a couple of housekeeping notes before we get started. We have 4 panelists. I'm going to introduce each of them and allow them to give you kind of a brief overview of what today's operations updates means. And then we'll go ahead and open things up for questions. Please submit your questions either via chat or you can direct message those to me. So again, thank you all for being here. Again, please submit questions through chat. Leave yourselves muted just to make things run as smoothly as possible. So as you have seen through the news release, we entered our crisis standards of care plan effective at 9 a.m. this morning. We're going to go ahead and start with our CEO, Dr. James Linder. Dr. Linder, can you just give us an overview? This obviously isn't a term that's familiar to everyone of what this means.
Sure. Thank you very much. First of all, if I think about answering the question why, Nebraska Medicine is focused on patient safety, being prepared, and transparency. And that's one of the reasons that we were named one of the top 5 hospitals for trust by the American Hospital Association this last year. We entered this operational status to be prepared. We've not yet reached the COVID-19 spike in our community, and this operational status positions us to respond to any spikes in the number of cases that we have to care for in the community, and doing so in a safe manner. I want to emphasize that if patients are getting their care from Nebraska Medicine, that will continue as usual. If patients want to come to our facilities for care, that continues as usual. What we've done is flexed our staff to be able to care for more patients should that arise.
I'm going to go ahead and move on next to Corey Shaw, who is our Chief Operations Officer. Corey, can you explain what got us here to this point?
Sure. So I think what everyone understands is that what's different about the Omicron variant is that it has, in a very short period of time, really stressed the entirety of our health system. Early on in the pandemic, we spent quite a bit of time focused on the impact on our inpatient capacity, which is still an issue. However, with the way the Omicron variant is spread in our community, the stresses on our ambulatory setting, as well as our testing platform and our perioperative environment has increased. At the same time that we've seen about a 10-fold increase in the number of our employees who are absent and dealing with COVID in their household or them personally. And so the combination of that increase in activity and the decreased availability of staffing has really put us in the situation we're in right now. And then we anticipate that to potentially get worse, as Dr. Linder indicated, over the coming weeks as the variant deepens its impact in our community.
Dr. Harris Frankel is our Chief Medical Officer. The community obviously wants to know how this will impact them. So what can patients expect?
Yeah, thanks, Kayla. And good morning to everybody. I want to first emphasize something that Dr. Linder said, and that is, if you perceive the need to seek care, you absolutely should seek care. And if you choose to seek that care with us, we welcome your pursuit of care with us. That being said, what might people expect? Well, it certainly is possible that appointments could be delayed and or rescheduled. There may be fewer appointments for diagnostic testing in our ambulatory clinics based upon staffing availability. Surgeries have been postponed and will continue to be postponed as appropriate. If you're involved in a clinical trial, it is conceivable that that clinical trial may be paused during this period of crisis standards. You may also see medical students or other learners, along with other support staff, used as support personnel that might not otherwise commonly be involved in activities of this type. Patient transfers from outside facilities will continue to be limited, and the criteria to accept those transfers will continue to be restricted. That being said, we will accept those transfers that we really believe that we have the higher level of care that is necessary and accommodate those patients as our census permits. Non-patient areas such as classrooms or conference rooms conceivably could be used for lower acuity patients to care for them, perhaps while awaiting discharge or things like that. So those are some of the things that patients might anticipate under the current circumstances.
Dr. Kelly Cockett is also with us today. She is a critical care physician and infectious disease specialist, obviously seeing things firsthand. Dr. Cockett, we just kind of want some perspective of what you're seeing through your eyes, what things are like in the hospital, and why we're at this level now.
Sure, absolutely. So as you've all already heard, we're seeing this Omicron surge. And although there's been a lot of media released that says this is milder, it is spreading rapidly, and milder disease does not mean that there are no hospitalizations. We are still seeing patients being actively admitted with Omicron infections. We are still seeing patients who need critical care level services due to COVID-19. And we had not truly transitioned away from our prior Delta surge in full in the hospital before these patients started to be admitted. With the speed at which Omicron is spreading through our community and the rate at which people are becoming ill, it is that volume of patients that can come into the hospital that really impact us, both for the ability to take care of patients in the building, but also because that spread is happening to our families and to ourselves as our healthcare workers, as you've already heard. Many of us have children in school or in other places. We have other family members that we may take care of as our primary or extended family members, and everyone remains at risk for this infection. We are also seeing that despite this community spread, we are not seeing a lot of masking in our general community. We still do not have the levels of vaccination from a primary series or boosting series that we would really love to see to help curb this pandemic and this current surge. And although we don't know when we will fully see our peak, I know from talking to colleagues in the last 2 days on the East Coast, we are at least 2 weeks behind where they are starting to think they are seeing their beginning of a plateau. So we have a ways to go. And so it is both in the hospital and in the community that I think we are seeing changes that we really would like to enforce as far as protecting patients, protecting our staff, and protecting the community as a whole so we can continue to provide that quality care we need to.
Thank you all very much for joining us. I'm getting some questions coming in now. Just a reminder for all the reporters that are on the call, if you could either submit questions via chat or go ahead and direct message those to me. That'll be the easiest way to handle things and keep things running seamless. Let's start. There's a question about employee absences. What have we been seeing as far as the number of employees out, and how is that impacting things?
Yeah, so as I mentioned, we've seen about a 10-fold increase in the number of our employees who are out, either because they themselves or a member of their household has had an encounter and been diagnosed with COVID. And that number includes every member of our workforce. So you think about it, we're dealing with shortages and staffing in our clinical settings, our inpatient, our clinic, our testing environments, our perioperative settings. We're also dealing with it in some of our critical support areas, our technology areas, our facility areas, where without that staff being here, the environment can't be maintained in order to be safe. So that's part of, again, the reason why it's important for us to think about this as a systemic impact as a health system.
An important question here: when was the last time these crisis standards were enacted?
This is the first time, Kayla. We've not had to do this previously. That being said, we've anticipated that this day could come. And yeah, we have prepared for this event, but never before in the history of the institution has this had to be undertaken.
Next question. Some other states are getting support for staffing shortages from the National Guard. Has Nebraska Medicine had discussions with the governor or others about getting additional staffing support?
We haven't had that conversation directly, but I'll point out that one of the challenges that we have is that the National Guard in Nebraska is comprised of Nebraska citizens. And those Nebraska citizens that have healthcare background are likely working for a healthcare organization as we speak. And so activating the National Guard to provide clinical support would actually deny local communities and local health systems, local skilled nursing facilities, clinics, you name it, from the staff that they have in place today. Now, there's certainly some logistical things that could be done. That's really not right now our primary challenge. It's really maintaining the integrity of the clinical team and the delivery system support that is required to keep that team fully functioning.
A couple of questions. I'll ask these two together. What are we seeing as far as the average length of stay for a hospitalized COVID-19 patient? And what's the general age range of the patients that we're seeing?
So Kelly, you might want to add what your observations are about age, but I can tell you from a length of stay standpoint, for those patients that are not requiring intensive care, so med-surg patients, those patients typically are staying somewhere between 5 and 6 days. Patients that require an intensive care stay where they might be ventilated, they may not be, but in an intensive care environment are closer to 12 to 14 days, depending upon a variety of circumstances. As it relates to age, Dr. Cockett might want to comment on that.
Sure. So I think we are seeing some transitions where we do see a lot of younger patients right now in the last 48 hours being admitted. And I can say that having been on service actively addressing COVID-19 testing and diagnostic questions in our hospital. Now, that being said, we still have multiple older patients who have different medical conditions, who are immunocompromised, or who maybe were not vaccinated or did not receive a booster, who are being diagnosed with COVID-19 as their primary reason for hospitalization. But again, we're still in this transition period where we have patients that we believe we're still dealing with hospitalizations from Delta and transitioning to Omicron. So as far as what the Omicron length of stay will truly look like, I think it's going to be a few weeks before we can speak to that very specifically for our community and our organization.
I think an important point that everyone should be aware of is enacting this status helps protect the availability of care for patients who do not have COVID-19. Okay, so on any given day, maybe 70 to 80% of the patients who are in the hospital now are hospitalized without COVID-19. We want to continue to provide that care. And by the standards we've enacted, we allow our staff the ability to serve both groups of patients.
We categorize surgeries by letters here. Those are things that the community might not be as familiar with. What kinds of surgeries could be postponed because of this?
So A, B, C, D, E is what you'll hear often referred to as sort of a case classification. And in a very general way, A, B cases have to be done now. There's immediate threat to a patient's life. C cases need to be done in order to assure that their case or their clinical condition doesn't degrade in a way that will significantly change their outcome. So for instance, many of our cancer patients and the surgeries we do for them are C status. And so it's really important for us to be able to continue to be able to provide that level of care, both in an inpatient and in an outpatient setting. D&E cases can be delayed a little bit longer, and it really comes down to the judgment of a clinician to decide where a patient stands within that continuum. What might be a B case for one patient might be a C case or a D case. Again, it depends upon the clinical condition, the evaluation of that physician and their judgment as it relates to that patient's needs.
Corey, and I'd like to add that I think that the decision as to the classification of the case type really is at the discretion of the physician in consultation with his patient. And that decision is nuanced. And at the forefront of that decision-making process is the safety of the patient.
And if I could just add to that in addition, if these surgeries are necessary and a patient does have COVID-19, we have policies and procedures in place to provide that care and that surgery. So we are not necessarily deferring critical surgeries because of COVID-19.
A question that was sure to come up, a hot topic being the mask mandate that we recently saw issued here in Douglas County. Obviously news today that the state has filed suit against the health director to try and stop that citywide mask mandate. Anyone want to comment on the mask mandate and how that could help the situation in our hospital system?
Well, I'd comment that COVID-19 is transmitted through the air. And a mask is the best way to prevent that transmission to other people and to protect yourselves. And so wearing masks, whether you have a mandate or not, is a really wise thing to do to flatten the curve, as we've known since the beginning of the pandemic. So I hope that everyone who's listening to this will take it on their own personal responsibility to wear an appropriate mask that provides protection for themselves and the community.
And aligned with that need for high quality mask use to impact this pandemic, we've enacted policies related to mask use for our organization, including stepping up the types of masks we use for our healthcare workers and our non-clinical staff to try to protect our staff and to continue to protect the visitors and patients that are around us. So including KN95 and N95 masks, and no longer allowing the utilization of any type of fabric mask for anyone entering the facility.
And Kayla, I would add to that, beyond the masking, it still makes great sense to follow those other non-pharmaceutical interventions that we've been talking about for the last 2 years. Distancing, washing your hands, be mindful of your surroundings, and just do things that will enable your protection and safety.
Dr. Cockett, this one probably I will direct towards you. We've heard a lot about the treatments and the short supply of treatments for the Omicron variant. Can you explain what those shortages are?
Sure. So much like we've seen throughout the course of the pandemic, as new medications are approved, particularly with these emergency use authorizations, we do not have the national supplies to treat every eligible patient. And honestly, we have allocations. So a certain number of these medications are provided to the state and to institutions. Right now, the number of those medications that are available are grossly lower than the number of patients who are eligible with new diagnoses of COVID-19. And so in order to treat the highest risk patients to prevent hospitalizations and death, we have a standardized triage methodology that is vetted and assessed to determine who is the most likely to benefit from those medications, and to do our best to use all of the medications we have available based on that triage system. And that is something we're seeing across the country. It is not just this organization or our community or our state. It is everywhere where we are struggling with this shortage based on these allocations and what is actually available at the moment.
I'm going to go ahead and read this question verbatim. Douglas County Commissioner says doctors don't make policy on COVID-19. What do doctors think of this ideology that politicians are the ones making public health decisions?
Well, I would answer the following way. I think that physicians have been all too willing to provide input to policymakers and advise on the medical context of the policies that are being developed. And I think physicians and other care providers have an instrumental role in shaping policy.
I think that does it for the questions that I have in the inbox right now. So anyone who is watching that has questions, go ahead and slide those in if you've got anything left. We have just a few more minutes available of the time here. Otherwise, any closing thoughts by any of our panelists?
Why don't we go in reverse order? Dr. Cockett?
My closing thoughts would be to reiterate that Nebraska Medicine is doing its absolute best to preserve a high quality of care for any patient that is seeking care at this organization. So we really want you to have faith that we are making every change possible that we can to do that and to serve this community in the best possible way that we can, given the current Omicron surge and the impact it's having. I would also urge the community, regardless of mandates or politics, to really consider how you can help our community, given the fact that we've had to enact these crisis standards of care by, again, getting vaccinated, getting boosted, wearing masks, social distancing, and avoiding large indoor gatherings, and hand washing. We need our community to help us to get back to our standard of care that we have all enjoyed up until this point.
I'm not going to try to improve upon that.
Smart man. Dr. Frankel?
Yeah, I echo everything Dr. Cockett said. To reiterate Dr. Linder's initial comments, we are committed to the communities we serve and the patients and other citizens within those communities. Moreover, we're committed to the safety of our colleagues and our staff, and everything that we are doing as relates to the enactment of crisis standards underpins our commitment thereof.
And I'll close by saying that Nebraska Medicine is consistently ranked high for patient safety activities. And it's because of our staff that we are able to achieve that ranking. So I extend my gratitude to all of our staff who make the care of patients possible on a daily basis.
Thank you all for joining us. If you do need a copy of the recording, just reach out to me or Taylor Wilson and we'll make that available. If you have any questions that come up later in the day, you've got my contact information. You can send that my way. So thank you for joining us. Thank you to all of our panelists, and everybody have a great day.